Well, hello and welcome to Lecture 23. This is Ward Stevens, and our topic for this lecture is the Medicare Access and Children's Health Insurance Program Reauthorization Act of 2015, commonly referred to as MACRA. Now, in our last lecture, we talked a lot about what the ACA has done with advanced payment models in the area of care primarily provided through hospitals. But one of the things that the ACA did not do was directly address pay for performance or value-based purchasing for physicians or other providers. And it probably needs to because physicians account for about approximately 20% of all cost and are a key driver of costs within the healthcare system. There is I would say very little that is done in healthcare that does not require a physician to order it. So physicians need to have the opportunity to play in this game as well. But the ACA did sort of indirectly impact physicians through ACOs. Remember, it's a group of providers, bundled payments. The hospital, the physicians, and everyone else is paid by one payment. And they have a key role in helping hospitals meet the requirements of the various hospital-based purchasing programs. So we've talked about acronyms before, and as a result of the legislation I just mentioned, a few of those are MACRA, MIPS, the MVPS, the QPP, and the SGR. And again, those aren't diseases, but they will impact you and your patients. Now, the SGR was a little bit older, but we'll get into that shortly. So this part of the presentation also has some learning objectives. Please review these. So there are two things that were done through MACRA. One is it repealed the sustainable growth rate, which we will talk about. And the second thing is that it replaced the sustainable growth rate, or the SGR, with what is now known as the Quality Payment Program, or the QPP. Now, the sustainable growth rate was implemented, I believe, back in the 1980s. And it was, or perhaps the 90s, doesn't really matter. But anyway, I should know that. But I'm not going to make you know it. But this was a formula that was developed to control Medicare physician expenditures. And what it did was that if expenditures were below certain targets, then pay could be increased, but pay would be decreased if expenses exceeded targets. And essentially what it did, it looked at an indicator regarding the growth of the economy, and we'll assume it was the Consumer Price Index. And if the Consumer Price Index went up, say, 5%, and healthcare spending per Medicare beneficiary only went up 3%, then physicians could be paid more. However, if the Consumer Price Index went up 3%, and Medicare spending per beneficiary went up 5%, then physicians would be paid less. And the fact of the matter is that it did not control expenses, mainly because physicians just increased the volume of services that they provided. But if the SGR had been implemented in some years, the pay cut to physicians for seeing Medicare patients would have been up to about 20%, which would be pretty significant. And the thing is that the medical profession, through the American Medical Association, the Osteopathic Association, through the various specialty colleges and so on, were very successful in lobbying Congress, to the point that before the increases ever went into effect, Congress passed the law saying, nope, we're not going to implement them. So this program was not successful in having an impact on payments to physicians. So what physicians must participate in the QPP? It's not really an option now. Well, those who have to participate include physicians, physician assistants, CRNAs, nurse practitioners, physical therapists, occupational therapists, as well as clinical psychologists and others. And each provider has a unique tax identification number, and there's a thing called the National Provider Identifier, which you will have one day, and it's used for basically signing up with insurance companies and so on. Now, you can be a physician, and if you accept Medicare to any great degree, you have to be part of this program. But if you're $90,000, if you have less than or equal to $90,000 in Medicare allowable charges, you don't have to participate. If you have fewer than 200 Medicare patients, you don't have to participate. Or if you charge fewer line items or kind of those things, CPT codes, or things like 99214 or whatever, if you have a small number of those, you do not have to participate as well. But the fact of the matter is, unless you decide not to take Medicare patients, it's highly likely that you'll be required to participate in the QPP. Now, how do you participate in the QPP as established by MACRA? Well, there are two ways that you can do that as a physician. You can either participate in an advanced alternative payment model, or participate in the merit-based incentive payment system, also known as MIPS. Now, you may recall from the previous presentation that alternative payment models include ACOs, bundled payments, and patient-centered medical homes. So if you are part of one of those organizations, then you are covered and you don't have to worry about MIPS. So under the advanced alternative payment model approach, there was some incentives that were involved with that. This is really not that important to know, but by participating in those programs, physicians could receive some additional payments. So the advanced alternative payment models also have some requirements of them, and they're pretty much already built into those systems. If you have if you're participating in an ACO or bundled payment, it's pretty likely that you're going to have an electronic medical record system. You'll be reporting quality of care, otherwise it wouldn't meet the requirements of those two programs. But another thing is that the model has to assume financial risk. In a bundled payment, since it is basically an episodic payment, there is financial risk. However, with ACOs, the one-sided ACOs do not qualify because there's no downside risk for the providers. So you remember, one-sided, you can get a financial reward if you control your cost, but if you have financial losses or it costs more, there's no penalty. So for your advanced alternative payment model to meet the QPP requirement, it has to be a two-sided ACO. And then there are certain patient volumes and payment amounts that have to be achieved as well. So the MACRA, this is just a short video. I'd encourage you to watch that, at least in the beginning. And then the one there on the bottom is a good one to watch, as it kind of shows where things are heading. So what is the focus of the MIPS program? Well, it will adjust payments to providers based on indicators measured in 4 areas. And those areas are quality, resource use, or basically cost effectiveness, advancing care information, or interoperability. Again, just using electronic health records is what they mean by that. And then also participating in clinical practice improvement activities, or performance improvement. And the in 2020, this is just where it is weighted in 2020. I believe it's the same for the current year. I know it is on the cost side at about 30%. So when the program began back in about 2017, there was a lot more of an emphasis on advancing care information or using EMRs, because many practices at that time, organizations hadn't gotten to where they needed to be. And over time, it switched from there over to quality and to cost. So it's also very important how MIPS is funded. MIPS is a budget neutral, and being budget neutral to the Medicare program, to the federal government. And while there are rewards, those are, or bonuses, those always come at the expense of poor performers. And so so if you don't do well in it, it can cost you. And another issue with it is, or what's been brought up, is participation in the program does have some significant administrative burdens. So how did it work? And the way it works is that they'll measure the program, say in 2021 in this example, and those scores actually don't get applied to your 2023 payments. And so these numbers may change from year to year, but there are a number of measures in the 4 domains which I shared before. And if you only score 0 to 15 points, you will see a pay cut of 9%. And you can also see just various scores there. If you get 60 points, you're break even. But if you get 60 to basically 85 points, you could have a positive adjustment, and more points, higher the points, a better adjustment for your practice. So it kind of it's a scoring system, and how you score impacts what you get paid or how your pay is cut. So it's very important to try to meet those different indicators and measures that the government is stressing. Now, there are some issues that have been identified with the MIPS program. One is that many feel that it doesn't really meaningfully increase quality. It's more of a focus on reporting on quality. And it also allows, kind of driving that is that there are numerous measures, and a practice can choose which measure it wants to pick. So if you're going to choose them, why don't you pick the ones you're going to do well on, and maybe you're not focusing on really where you should be focusing to improve the quality of care provided to patients. Another issue is that just comparing, how do you compare providers that aren't using the same measures? So, when this information is publicly reported, is it really meaningful to compare 2 practices where one is measuring, say, a certain type of infection, and the other one's measuring a different type of infection? And then I mentioned before kind of the administrative burden, that a concern with it is that your return on investment or the increased payment that you might receive is not enough to cover the administrative burden of trying to cover the cost of all the work that you have done. And that's been an issue with kind of quality reporting systems for many, many years. Back in the 1980s, early 90s, insurance companies tried to put these programs in place, and would say, oh guys, physicians, we'll give you a 2% bonus if you just report on certain measures. And physicians would often come back and say, well, that 2% equals X. I will just say $1,000, but it's going to cost me $1,500 to get you those numbers, so that we're not going to do it. So that has been an issue with quality reporting for many, many, many years. And then another issue is that the feedback from the program is often not very timely. And so You know, one of the complaints was that, oh, this information is not going to come back until 6 months after the end of the year. So, you know, it's hard to just in identifying issues in a timely manner. And you know, if it could be more timely, then perhaps it might have more of an impact on more patients. Now, another way that physicians can meet the MIPS requirements is to participate in what is known as a MIPS value pathway, or an MVP. And currently, there are about 7 pathways that you can see listed here. And under this type of program, here's an example of the MVP for anesthesia. And you can see here that they are required to report on one of the 4 following quality measures. And then in addition to that, they have to implement 1 high or 2 medium improvement activities. And you can see there are 11 improvement activities. Some of them are medium and some of them are high. So if they do this and they report on 4 measures, they are meeting the requirements of MIPS and the quality payment program overall. So unless you are a pediatrician or a specialist that only provides care to pediatric age patients, if you are in a specialty that totally avoids all people, older people, those 65 and older, you won't be impacted by MIPS or MVPs. But unless you meet that criteria, you will be. So what are you going to do? Well, the only encouragement I would provide is to follow the requirements of the program, or make sure the practice that you're in is doing so, and you provide care that is safe, timely, effective, efficient, equitable, and patient-centered. So here are a few abbreviations, and if you have any questions, feel free to get in touch with me. Thanks.